Hello, 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 HIMSS22. I am Bob Murray, the Chief Medical Officer of NextGen Healthcare, and we're going to have a fireside chat with Jerold Greer, who is with Daymark Recovery Services. So Jerold, you want to just let everybody know kind of who you are and what does Daymark do?
Thank you, Bob, and thank you so much for inviting me here today. I'm the Chief Information Officer of Daymark, and we are an agency that serves about 50,000 patients in the context of behavioral health care in North Carolina, about 30 counties in North Carolina.
Wonderful. And I know you use a number of different NextGen products and services, et cetera, but today I think we're going to be focused on how you're using data and interoperability to really affect clinical care. So maybe just to kind of set up for folks, what is the problem, or what's the thing that you need to solve, and then we'll get into how you solved it.
The issue is that we are starting a new care management program in North Carolina. What's interesting about this is that we're a behavioral health care company, but in this new program, we're going to be challenged with providing care management for the whole person. So if somebody has an issue with diabetic supplies, then we need to try to find the solution for that issue with diabetic supplies. If they're having a problem getting their insulin, if they're having a problem with transportation to their providers, then we need to solve that problem, to include all the elements of social determinants of health. So if there are housing issues, financial issues, then we need to have all the tools that are available to us to help address those issues.
And that's certainly a problem that a lot of folks are having these days. It's both with collecting the social determinants of health data, making sure that that's incorporated in the system the way that the entire care team can take advantage of. And then, of course, if you're referring back out of your system, making sure that those referrals are smooth and then you can loop back around in them. So I know that Daymark in particular is having some innovative work in how they're receiving the data and how they're kind of using that data in a proactive sense. So maybe just talk to us a little bit about that in the context of care management.
So we anticipate having a workforce of about 200 care managers, and each of those care managers is going to have a very large caseload. And we know that a lot of times providers get lost in their caseloads. They lose touch with their patients, and most often they're catching back up right before they do session preparation. So I have an appointment with the patient in about 15 minutes. I'm going to quickly glance at the chart and identify the history of the patient and come and do an interview with the patient. I might learn new things about the patient during that patient interview, and then I'm reacting to those new things that I discovered during that patient interview. Our involvement with the patient is going to be 24/7. It's essentially a lifetime engagement with that patient, and we need to know what's going on with the patient in a more real-time basis. With these large caseloads that they have, then how do we manage keeping up with the patients and what's going on with their lives at all times? So with the technology stack within NextGen, we created a dashboard for the care managers that's giving them real-time alerts of what's happening with the entire healthcare ecosystem. So what we do is we leverage NextGen's being a partner in the Care Equality Network, and we continuously reach out across Care Equality to consume CCDs from every provider in the healthcare ecosystem. We've got an interesting area around Metro Charlotte and Metro Raleigh, North Carolina, where we have these major healthcare systems: Atrium, Duke, Novant, Wake Forest. And often for a single patient, when we reach out and ask the network, what's the latest information that you have on these patients, then we may get 5, 6, 7 different responses back. And we created, using NextGen's technology stack, we created an engine that constantly absorbs that information, looks for new information as opposed to the information that we have on file. And if a care manager is logged on to their dashboard, then they're going to get an alert. Almost like you get an email alert across your screen. Then let's say that a new patient, one of their patients, a patient goes to their primary care physician and they're newly diagnosed with asthma. Then almost in real time, they're going to get one of those little alerts that says, patient has asthma, and they can click on it and they can assign themselves a task in the context of that alert. But if they're not signed on at that moment or they're doing something else, then that's going to go to an alert queue where they can go in and say that I need to update the care plan. I need to update the assessment for that patient based on this new information that I have.
Wow, so that's terrific. Let's back up a couple steps. So it sounds like the dashboard that you created with NextGen technology, that's within the EHR, and it's both a view of the patient at the patient level, but also it has a queuing system and an alert system. Is that all correct?
What we do is we have the NextGen framework that's pulled up basically on a dummy patient. And then that launches a template that then launches an application within the template. So that application then is running a dashboard that prioritizes their caseload, and each patient can be open. That dashboard has a series of indicators that's actually showing them from all of this interop data that's coming in. Say the patient 1 through 20 in the list. They can sort to the ones that have the largest number of comorbidities and say that this person has hypertension, cancer, chronic kidney disease, and there's little indicators for each of those across. And they can also sort by, we actually came up with our own algorithm for risk, and that uses a mechanism of counting the comorbidities, the number of ER admissions in the last 90 days, the last emergency room admissions in the last 90 days, and they can sort on this risk score. And when they click on that patient and expand them, then they have all of the ADT feed that we get. That's another element that comes in by nature of the statewide health information exchange in North Carolina. So I'll open that up, I'll see each ER admission, each inpatient admission, and right beside that I've got the CCDs as well. So I can cross-reference right from that point to all of the ADT information I see, to the CCDs that I see, and then I can see all the chronic occurring conditions that have been pulled in from the outside. So this dashboard, from a row of a patient, we can then pivot to the patient context and work completely in that patient.
That's amazing. So you're combining both the CCD information, HL7, and ADT information all in a view at that care manager. Sounds like you're trying to maximize the care manager's time and efficiency by focusing on the patients with who need the care the most. And then from there, the care managers are already in the EHR. They can jump into the chart and then update the care plan or inform the rest of the clinical team based on the information that's coming from that kind of interoperability, ecosystem or web or multiple feeds that you have going on. Did I get all that right?
You did, and you helped bring up a point that I should mention. The model of care management that we're implementing is one that North Carolina invented, and it's called tailored care management. And within that model, there are what they call triggering events. And we are required to respond to those triggering events. So an ER admission would be a triggering event, and we have a required timeline for doing that. It's actually built into the definition of tailored care management that we have to have a real-time ADT feed. And that's probably the most complex of the technology hurdles that providers that need to provide the services have to cross. Interestingly, we're the only one that have crossed that. In fact, we had to be certified as a care management entity, showing that we have the technology stack in order to provide the service. And maybe this is too revealing for such a session, I'm not really sure, but everyone else in the state that's going through the application process, they have to go through an NCQA review. North Carolina essentially delegated the certification process to NCQA. And one of the rules that North Carolina gave to NCQA in the review is that it's okay for any of the providers to have a contract. And that signed contract has a deliverable that says they will do this. So they don't actually have to demonstrate that they can do something. They just have to demonstrate that they have a contract to deliver, right? So we are the only provider that approached it from the perspective of saying, we're going to demonstrate that we can do it. We're actually going to do a demonstration of our platform to NCQA that we can do everything that's a deliverable. So when we have these triggering events, that's the reason we have that real timeness built into it, is that the rule within North Carolina is that a care plan has to be updated, the assessment has to be updated, to basically update the context of that patient, because we go on our life journey and our life is never the same once a day goes by. Each of those events happen in our life. And North Carolina is using the language in reach. So as much as possible, they want us to respond to circumstances within the circumstances, not after. It's not follow up with the patient 7 days after this happens, or within 30 days after this happens. If you can, then try to respond to the patient in the context of their hospital admission, so you can start planning on what's going to happen after the hospital admission while they're still there. If you can, let's walk out the door of the emergency room with the patient.
That's terrific. So why do all this with NextGen? What is it about the NextGen EMR or the technology that maybe makes it easier, or at least more straightforward for you to do it there as opposed to with another vendor or something?
I've been working with EHR implementations now for 33 years, and there comes a time, I can remember multiple times in my career, where there's a certain point that you reach where it's like, well, I've done some really creative things, and so how can we go beyond that? And I've always been surprised where there's this new jolt. And so when we were challenged with this program, then we took a deeper dive into the technology stack that NextGen offers. So we've been running NextGen since 2016 for our programs, and we'd already implemented care equality, and we'd already implemented the HIE interface, and we were excited about those. Those were new, and we were front runners in the state of doing that. But it's not just about how I remain excited, but it's also about how to keep a team charged. And so when we were doing that review of the technology stack that NextGen offers, then we were recognizing that we could put this piece together and this piece together and this piece together, and with our own piece leverage all of those pieces. And the team was entirely energized about that. So the IT team was entirely energized about that. I happen to be lucky too to be a part of a behavioral health organization that has an IT team, because some behavioral health organizations are lucky just to have a guy that's the IT director that's nothing but the vendor correspondent, asking the vendor, can they do this? I have a development team, and that's kind of rare in behavioral healthcare. So I'm excited and blessed really to actually have that. So it really became about having a team that was fully aware of NextGen and what NextGen could do. And I think I even see in our environment in North Carolina where every other provider that I'm aware of, at least, is actually saying, my EHR can't do what we need to do for care management, so I'm going to buy a separate care management platform. And they're going to run these platforms side by side. And I step back and I think, this is kind of strange. North Carolina just went through this process called Medicaid transformation. And one of the reasons they did that is because in the Medicaid system, no one was fully responsible for the person. So there was no real value in outcomes. So they said, we're going to outsource Medicaid essentially and bring in commercial payers, PHPs, that are responsible for the whole person, behavioral health care and physical health care. For the people that had more chronic healthcare, behavioral health care conditions, they decided to create these other types of payers called tailored plans. And they too would be responsible for the whole person. So we looked at, we've implemented an EHR, unlike most other behavioral healthcare providers that have chosen behavioral healthcare specific EHRs, and say, this platform excels at dealing with the whole person. Why are these other providers going out and saying that we need a separate solution for care management? Because the state has said we want to treat the whole person. So now you're taking a behavioral health care provider and saying you want two separate systems, and you got to log into this one to do this, and you got to log into this one to do this, when we're talking about bringing things together more to one view. I said, I don't know that that makes sense if we have the tools to do it all. Exactly. So we saw that care management's a little bit different than what NextGen normally does, but there's no reason why we can't put the tools together and leverage population health. So one of the things we did as part of this is bring the NextGen population health tool, Eagle Dream, into the picture, because one of the things we have to do is address gaps in care. So we had to have a mechanism to digest claims from the outside, 2 years of physical health claims that would be coming into us to merge with both our EHR data and the data that we're bringing in from the outside world via both care equality and the HIE, and bring that into one integrated view. So NextGen was just a perfect launching point to do that.
That's a terrific and amazing. So, I mean, with whole person care, you're both combining the behavioral health aspect of things and the physical aspect of things, one care team, one care plan. And then in terms of data, you're combining both the insurance claims and the EHR data with Pop Health, as well as kind of the live, real-time HIE and care quality and ADT and HL7 feeds. I mean, it's just amazing. How long do you think it's going to be before we're going to be able to see some outcomes that you'll be able to report back to the state?
Okay, you just asked me the tough question. One of the things let me put it this way. I have told our staff that we treat outcomes like a job description. So most people look at outcomes from a historical perspective. There's something like 67 HQMs that are built into the North Carolina Medicaid program and baked into tailored care management. That's a lot to keep up with. And ultimately, you want to score at a very high level when the state says, okay, here's what we've got. Because the state's ultimately responsible for doing that. But we are getting the real-time data. So when we look at measures like controlling hypertension, controlling diabetes, then what is our excuse for not leveraging all the tools that we have and looking at, if I were to measure this today, what is the value? Okay, I've got to the end of the year before there's a formal metric that is calculated. What can I do today that changes the circumstances from today until the end of that measurement period? So we're not looking back and making a plan for the future. So we're not saying, we're accepting what it is now and next year we'll do better. We're seeing today and we're going to do better tomorrow. And we're going to do better the next day. It's a constant reevaluation. So that's what we're doing, is we're giving that job description, and the care manager has to perform every day. And the quality measures at a patient level ultimately become the job evaluation for that care manager.
Do you have any, stories or anecdotes from some of the patients that have been involved with this kind of comprehensive approach to both the care and the data surrounding the patient?
First of all, they're a little surprised. They say, "How did you know that?"
Call them in the hospital room, and they're still there.
So once you get past that, then they feel this. It's almost a sense of comfort that they're not looking out just after themselves, that they do have somebody that's helping to look after them. So without the metrics, to speak, being very early on in the program yet, the fact that we're getting that kind of feedback, almost a difference in the countenance of the patients, is extremely valuable. And it's very rewarding to the care managers that are serving the patients.
And I'm sure our team would love to hear some of those stories from the patients. So if you can collect some of those for us, we'd love it. So what is next with Daymark and care management and whole person care?
Well, quite frankly, we're ramping up this program, and I think as a lot of providers, well, basically anyone, anywhere is challenged with right now is hiring. So we have a workforce right now. One of the things I didn't describe about Daymark is we're essentially behavioral health emergency rooms across the state. So police, EMS have been essentially trained that to recognize the patient's circumstances. Do I take them to the emergency room? Do I take them to Daymark? And we have inpatient crisis programs, so they even know if they should come to one of our outpatient clinics or if they should go to one of the inpatient clinics in their communities. So one of the things I think that we're going to see is that a lot of the people that are currently working in roles that have been what has been Daymark's historical DNA are going to be interested in these new roles. So how do we balance the both? How do we take our existing workforce and say, you want these positions, but yet we need to keep continuing to provide this service and have the licensed staff, professional staff in those roles and meet all the demand for those positions with the existing staff that are out there. And to make things a little bit more interesting, is that in behavioral health care in most states is divided up into catchment areas. They're basically non-compete zones. That's not true in North Carolina. So we're going to be competing with other care management providers in our own territory. And not so much at the patient level. Patients are going to choose. So it's up to us to be the best provider and to have the best reputation in order to have the patients come to us and have those assignments to us. But staff, people have different weapons to use to attract the staff, and that's going to be a huge challenge.
Yeah, I mean, as a healthcare provider myself, obviously, I know that they want technology that works for them, right, to help them do their job and take care of the patient. And many of them, in both the physical medicine space and the behavioral health space, are just philosophically drawn to that whole person care, that they know that they can't do their job as a therapist if the patient's not medically well. And we can't do our job as primary care doctors when so much of what we see is behavioral health. So a terrific overview. It was really great talking to you. Let me just open up, and anybody in the audience has any questions? Anything else you'd like to hear more about? Kevin? Kevin's one of our InterArt folks. Wonderful. Okay. Anything more that you'd like to say? Anything final words for this group, Jill? Okay. Well, thank you so much.
Yeah. Just thank you again for the opportunity to speak about what we're doing, because we're very excited about it, and sometimes it's good to kind of have an outlet rather than just kind of preaching to our own staff on what we're going to do. Sometimes it's good to kind of sit back and reflect on what we have done so far.
Well, done amazing work, and we look forward to more in the future. So thanks again, Jerold from Daymark Behavioral Health Services.